everyone. The back pain generation etiology lies mainly with the disc and the disc degeneration and facet arthropathies and large disc which do not have any deficit, but they do generate a lot of back pain. Image-guided blocks are diagnostic tool to confirm improvement in patient symptoms and therapeutic tool to reduce pain severity. These can also be used to delay in unfit patients when we intend to do surgery and patient is unfit due to for the optimization purposes. And these are not risk-free procedures. There are vasculature, arteriovenous plexus, nerve roots, ganglion, dorsal root ganglion, and dura, which can be easily damaged. And whenever we do injections, we do look for these. I have had my share of encountering these blood and CSF leaks during injections. Indications of epidural injections are acute pain, chronic benign pain, and sometimes there are specific indications like radiculopathy and spinal stenosis symptoms and chronic low back pain. And there are certain contraindications also. The absolute contraindications are pregnancy, primarily due to Siam use, allergy, Cauda-Equina syndrome, coagulopathies, and then there are relative contraindications of diabetes and the position related in glaucoma and respiratory insufficiencies. Material used for blocks, the local anesthetic is used primarily for diagnostic purposes. And when we use local anesthetic with a steroid, it works as diagnostic and as well as therapeutic purposes. Steroids used are two types, particulate and non-particulate. Particulate are, we usually prefer triamcinolone, and methylprednisolone is not so commonly used. The particulate have intermediate to long-term effect, pain relieving effect, and non-particulate are short-lived. 2E needle can be used because it has a blunt tip to avoid the risk of dural punctures, but we usually use 22, 23 gauge spinal needles. The mechanism of action of steroid is anti-inflammatory and direct neuromembrane stabilization, and also by blocking nociceptor C fiber conduction and prostaglandin synthesis. And this reduces nerve edema and decrease sensitivity to prostaglandin dorsal neurons. The blocks can be used, not all disc prolapse end up having surgeries. We have seen in our practice, and they do regress. And unwilling, unfit patient, when we give blocks, and we tide over the pain, and if the patient goes in the natural regression, it's a win-win situation for everyone. Coming to approaches for lumbar epidural space, this can be interlaminar, transforaminal, and caudal. And then there are facet and median branch blocks and SI joint blocks, which have to be handled a lot of time. Interlaminar steroid injection can be given both by blind and image intensifier guidance. We prefer image intensifier. Here we can see the needle placement, the dye injection in AP and lateral projection to see is it lying posterior to thecal sac, and then the dispersion of dye after injecting the steroid. There are a lot of complications, infections, the neurogen nerve injury, paresthesias, dural punctures, epidural hematomas, CSF fistula. These largely can be prevented by proper needle placement, and sometimes needle placement can be difficult in post-operative patients. Coming to transforaminal epidural injections, it delivers drug close to nerve, and caudal interlaminar are affected by absence of ligament, yellow ligament, and the scarring. So we sometimes have to choose transforaminal epidural injections. There is a safe window to place the needle. This shows, so people prefer in epilateral, I prefer in epilateral position, but people do, especially pain management, people do use oblique needle entry. We place the needle inferior to the pedicle, and by this approach, we can block one nerve, and that we can achieve blockage of both traversing and exiting nerve root, and S1 block can be given through S1 foramen. And this also have complication, no, not as much as epidural injections, but it can be technically difficult when there are posterior implants in situ. Caudal epidural injections, yes, we rarely do it now, but there are certain indications. And it can be done by both blind and with image intensifier. With image intensifier, it's preferred to see the placement of needle and dye and the dispersal of the dye. And there is, again, ultrasound-guided caudal epidural injections also available. Disadvantage, it required lots of volume compared to epidural injections, interlaminar injections, and that it leads to dilution of steroid, and then there can be similar complications like other. It is less efficient in relieving symptoms compared to interlaminar epidural injections. And this is a study which shows definite volume change after 1 month of post-injection. Well, it is evident in that paper, but we need more evidence. Then coming to facet joint is not only about the joint space, it's about cartilage, subchondral cyst, collapse of and marginal lipping, and complete loss of articular surface, which gives pain. We can give diagnostic facet joint block, and it is very important to localize the source of pain. And we can use median branch block, multiple median branch block, and if we are able to confirm, then we can go for radiofrequency ablation of the median branch. Coming to SI joints, to diagnose pain present around the SI joint, clinical tests, stressing prove that SI joint is the culprit, and selectively infiltrating the joint can reduce the pain for mid to long term, even up to 1 year. And if need repeated blocks, dorsal rami of S1 to S4 roots, and we can do radiofrequency ablation by self-cooling electrodes. Key points, there are specific indications, as I said. There are absolute contraindications. Fluoroscopy guidance ensures proper placement and delivery of medication. Transforaminal steroid injections deliver corticosteroid close to the nerve pathology. Interlaminar ESI have better efficacy than caudal blocks. Complication related to needle placement and drug delivery, we have to be always vigilant about. Thank you.